We present a case of a 40-year-old male, followed for ascending aortic aneurysm with rapid growth over the last year. Both his father and uncle had replacement of the ascending aorta due to aneurysm. Preoperative CT scan showed enlargement of the aortic root and of the ascending aorta. Pre-op echo showed good left ventricular function with mild aortic regurgitation. Medial sternotomy was performed. The pericardium was opened. We inserted a central aortic cannula and a multi-stage venous cannula through the right atrium. Retrograde cardioplegia catheter was inserted in the coronary sinus. The aorta was clamped and transected. Anterograde cardioplegia was given into the left and right coronary ostium. When we reached our target core temperature of 26 degrees, the circulation was stopped and we removed the clamp. The aorta was cut back to the underside of the arch, and antegrade cerebral perfusion cannula was inserted into the innominate artery. ACP was started, and we started suturing a 30 mm graft with a sidearm to the proximal arch with a follow running suture. After clamping the graft, we de-aired, and arterial perfusion was restarted through the sidearm. We started to rewarm the patient, and attention was now directed towards the aortic root. In each commissure, a plegited furrow suture was placed. The coronary ostia were dissected out with buttons. In each button, a stay suture was placed. Dissection was performed around the aortic root to make sure that we had gone down below the nadir of each cusp. The aortic sinuses were trimmed appropriately, leaving a decent cuff along the commissures and down into the sinuses to allow suturing of the graft. Plegeted 2O sutures were now placed from within the aorta underneath the valve and brought outside, taking care to maintain them in the same plane and avoiding the placement of sutures in the region of the membranous septum. A total of 7 plegeted sutures were placed. The plegeted sutures were passed through the graft and were tied down. The commissural plegeted stitches were passed through the graft and the commissures were resuspended. Each sinus was now sutured to the graft, this being the hemostatic inflow line. The left coronary button was implanted into the back side of the graft with a running 6-0 suture. The distal and proximal grafts were trimmed to the appropriate size. An end-to-end graft anastomosis was performed with a 4-0 suture in a running fashion. The right coronary button was implanted into the anterior aspect of the graft with a running 6-0 suture. After the airing maneuvers were performed, the cross clamp was released. The patient was weaned off cardiopulmonary bypass without difficulty, and decannulation was performed. The sternum was closed using an augmented sternal closure system with adjacent plate and screws. On post-op echo, the left ventricular ejection fraction was 15%. The aortic valve had no regurgitation. The patient was extubated 5 hours after surgery. Surgical drains were removed on postoperative day 2. The patient was transferred to a regular ward on postoperative day 3. The patient was discharged home in good condition on postoperative day 6. Thank you for your attention.